Clinical protocols are designed around the typical patient, the expected presentation, the ordinary response. They capture the center of the population distribution. But extreme harm does not come from the center. It comes from patients at the tail, rare presentations that the protocol was not built to absorb. Probability mass and damage capacity are not co-located in patient populations. Where typical outcomes concentrate is not where catastrophic outcomes live. Near the center of patient presentations, clinical harm is bounded and often reversible. In the tail, sepsis, multi-organ failure, acute decompensation, harm is large, accelerating, and frequently irreversible. This asymmetry is the formal structure of clinical fragility. The harm function bends upward as conditions move into the physiological extreme. Small additional stress, once past a threshold, produces large additional damage. The protocol does not account for that bend. For a fragile patient, toxicity does not grow proportionally with dose above the therapeutic window. It accelerates. Twice the overdose does not cause twice the harm. It causes more, sometimes far more. This curvature in the toxicity function is the signature of physiological tail fragility. The patient becomes increasingly vulnerable as exposure moves further into the extreme. Not all patient populations distribute risk the same way in the tail. Some groups show rapidly declining risk beyond typical presentation. Extreme outcomes are very rare. Others retain substantial probability of extreme deterioration, far from the average case. Standard clinical scoring systems based on averages cannot distinguish these two populations. For fragile patients, tail shape determines how often catastrophic outcomes arise. Mean and standard deviation cannot capture that structure. Two patient cohorts can have identical mean risk scores and identical score spread, yet differ substantially in tail behavior. One cohort places almost no patients in the catastrophic outcome range. The other places a significant fraction there. For fragile systems, what matters is what happens when patients deteriorate far enough to become irreversible. That is not what average-based clinical metrics capture. The frailty index and standard scores miss tail structure entirely. The tail of the patient risk distribution is not simply a region of low probability. It is where qualitatively different outcomes live, outcomes the protocol was not designed to manage. A patient who tolerates moderate physiological stress may collapse under a large one. Ruin in clinical terms is not a scaled version of difficulty. Clinical models built on average patients fail at extremes, where care is most consequential. The tail exists, has structure, and carries a different kind of harm.